Good evening, Leanne. Good evening, everybody. All right. So as Leanne had said, today we will be looking at autism, and I just want to put it out there that autism is a very broad spectrum type of disorder. And as we go through the notes tonight, you will be able to see that because it's such a broad spectrum, people can be diagnosed with autism, but it can be for many different reasons and many different understandings. Only professionals can diagnose. The reason why we're going to be doing the class tonight is to create knowledge and awareness within ourselves that if we pick up certain symptoms or behaviors from the children in our class in their early childhood years, we are then able to alert our seniors, our principals, our HODs, or whoever it may be, to get in touch with the parent and have the child sent to be assessed because you suspect that there might be some sort of disorder. But obviously, remember that you do not report directly to the parent, you go to your senior, and if you are the senior, you need to have your ducks in a row and you need to get a professional to sit in one session with you and just observe the child before you say anything. All right, enough of the politics, let's dive into it. Understanding the autism spectrum. This is a comprehensive guide to neurobiology, diagnosis, and lived experience. All right. So neuro, whenever we see the word neuro, we need to understand that it is referring to the brain, or it has something to do with the brain. So it's how the brain develops, how the brain works. The diagnosis, that is when the child is then labeled by a professional to say that the child is now autistic. All right. And then the last part is lived experiences. That is obviously what you will find in your class, or you can refer to the parents and ask them if they also pick up the same behaviors. A lot of the times, the parents won't be aware of it because it could be their first child and they might just think that it's normal behavior or whatever the case may be. But yes, if you pick up any of the symptoms that we're going to be going through tonight, please be aware of it and save a child's life. Have him diagnosed as soon as possible so that he can have a lovely life and he can live life to the fullest. Okay, next slide. What if? What is it? Okay, so we spoke about autism. We said it's a broad spectrum. Now we're going to dive a little bit more into it. It's a it's a neurodevelopmental condition rooted in atypical brain wiring from birth. We also say that it's a broad spectrum, as we did earlier, ranging from individuals with severe learning disabilities and high support needs to those with cognitive strengths and high IQ. I don't know if you guys have ever watched the movie Rain Man. He has a very high IQ and is able to memorize numbers and do sums and maths calculations. There's a series on Netflix also. It's called The Good Doctor. You can also make a note of that. Rain Man and The Good Doctor. Those are both movies based on people with. Sorry, my words are getting lost. Both people based on autism. Whew. All right. Um, an example of natural neurological and cognitive variations is what autism is. Like we said, it is very diverse, it is very broad. Not everybody that has autism falls in the same category. There's very many different categories for them. Some people who have autism are non-verbal, which means they don't speak, but they are able to show you through sign language what they want. And that sign language could have been something that they learned, or just merely pointing the finger in the direction of the thing that they want, or making a shape with their hands showing them what they want. All right, usually you will see the little children, when they want their father and the father wears a beard, they will always tug on their chins like that to show that they want their father or the grandfather or the male figure in the house that wears a beard. All right, so it doesn't have to be special sign language that you have to go learn because you want to stand in parliament and translate when they're doing their stuff. Okay, you just basically need to understand what the child is trying to tell you. Like we said, there are those who are verbal and there are those who are non-verbal, those who speak and those who don't speak. So now we're going to discuss what autism is not. It's not a disease, it's not an illness, and it's not something that can be cured. It's not contagious. You cannot get it from sitting next to somebody. It's not like coronavirus. So please don't be scared if you come across somebody that you suspect might have autism. And it's also not caused by parenting style, lifestyle choices, or specific diets. Like we said earlier on, it is usually from birth that the person is born like that. The neurobiological wiring is autistic from birth. All right. Uh, do we have any questions? If you are too shy, please pop the questions in the message box and we will try to answer you. Or if you want to stop us in between, you are welcome to use the hand raise emoji to get my attention. All right. Now we're speaking about the neurobiology, what happens in the brain of a autistic person. ASD, autistic spectrum disorder. Okay, so it can either be a rapid early growth, with infants and toddlers often experience a period of unusually rapid, accelerated brain growth. That means it could be that the brain grew too fast. Then we have atypical connectivity, and that is alterations in the brain circuitry, specifically in networks governing social interactions and attention. So atypical connectivity is those people that do not mix well with other people. They get a fright if you walk up to them unexpectedly and just start speaking to them. They are very, very sensitive to the outside, to strangers. They will start panicking, and that's why it's important for us to learn about all of these things so that we don't think to ourselves, ag nee man, die kind is nou net aspres. Nee, hy's nie aspres nie. Daar's iets verkeerd met hom. There's something wrong with him. All right. So we need to familiarize ourselves with the last one on the neurobiology, and that is early onset. These structural and connectivity changes can be detected well before behavioral systems physically manifest. So this is for that people that go to private hospitals and they can do scans before the time and they can tell you what disorder and what blood type and what color eyes and all of that the child is going to have. For the rest of us, we will just get it when it comes there. Surprise! You know, you see your child has a problem, the teacher calls you in, but usually you are aware of it already, because if you had children before or if you look at the children around you with their child's age, you will notice there is a distinctive difference in their mannerisms, their behaviors, their growth, and so on and so forth. All right. Next slide.
Sorry, Sophia, I just want to add something on the early onsets.
Okay.
The early onsets refers to the signs and symptoms of from a very young age. So basically, when we say early onsets, we mean 0 to 3 0 months, basically from birth up until 3 years of age. So this is where the structural and connection changes can be made and can be detected well before the symptoms.
Oh wow, that's really interesting. And thanks, man. Are there any questions amongst the students? Nobody. The student that asks 2 or 3 questions tonight is going to get 200 rand. Okay, I don't know from where, but yeah, I'm going to get 200 rand. Let's see. Okay, so now we're going to speak a little bit high grade English. We're speaking about etiology, which is the architecture of risk. So if you want to know how prone you or your child is to autism disorder. Number one, it could be in genetics. That means your oma, your upa, your auntie, your gogo, whoever had it, and so there's a likelihood that you or your child might have it as well. Right? Um, 10% linked directly to known genetic syndromes like Fragile X. I'm not going to say all of those other things because I can't pronounce it. But just know that it can be passed down from generation to generation whenever they speak about genetics. Then, environmental modifiers. Prenatal and perinatal factors such as secondary risk includes advanced parental age, premature prematurity, and sodium valproate exposure during pregnancy. Okay. In plain English, advanced parental age means die aunties wat babies het op hulle ou dae. In their old days, they have large lammetjies, they have babies. And what they mean by old days is actually offensive because I fall in that category as people over the age of 40. All right, so it is always advised, women are always advised, if you want to have children, try to have your children before then, because after that, your eggs are old, for use of another term, almost expiring. I think my diplomatically correct us. Yeah, and so there's a high risk that you might have a child that has autism spectrum or Down syndrome or something like that. All right. And then the last one they speak about there, you can go Google sodium valproate exposure during pregnancy. The first one that post the answer to that in the group, you will win a prize. All right. Next slide, please, Leanne.
Okay, let me just quickly explain the last one. So the
Okay.
last one, the last section
Oh, I never
explains.
saw that one. Sorry.
No, it's fine. Can you actually hear me?
Yes, I can hear you clearly.
Okay. So the last section explains how genetic and environmental factors may affect the brain development. For example, epigenetic changes. This is how the genes or your DNA will be exposed, and then it will change without altering the DNA itself. If it makes
Uh,
sense.
no, tell us again.
Okay, so it's basically your genetics that
Yeah.
is exposed without altering the DNA. So this basically means that it's your genetics and then obviously your environmental factors that will change your DNA. Then you will
Wow.
get autism in that way. So it's like oxygen deficiency. If you are born with an ability that your neck, maybe inflammation during pregnancy. It can be quite a few things that will actually help to
Awesome.
to level up the autism, if I can
Yeah.
explain it like that.
I think that's a good response to people who say, but nobody in our generation had it. Because of that person's exposure to whatever it was, the DNA now changed, and that's why the child is born with some sort of disorder or other. Am I understanding it correctly?
Yes, that is basically like that.
Okay, awesome. Thanks, Leanne. All right. So, um, what spectrum, um, autism spectrum in the diagnostics manual that they use internationally, it is said there are two pillars for diagnosis. One is social communication and interaction, and that is deficits in social reciprocity. So, what that basically means is if someone, remember, social is always when you're engaging with other people. So, if there's a defect in that child engaging with other people, it could be a red flag. Secondly, they say atypical non-verbal behavior, lack of eye contact, fewer facial expressions. All right. So, the pillar one is based on social communication and interaction. I always say this in our videos, whenever you see social, make your life easier. It just basically means how you engage with other people around you. All right. So, is there something else? the way that they approach people? Is there something wrong with the way they respond when people speak to them? Do they understand people? Do they understand expressions? Do they not understand expressions? Are they able to pick up when somebody is angry and then they step back, or do they put themselves in danger? That's basically what Pillar 1 is speaking about, right? Difficulty developing, maintaining, and understanding relationships. Okay, that sounds a bit like me, but anyway, we carry on. The pillars of two pillars of diagnosis. Pillar number 2, restricted and repetitive behavior. Stereotyped movements like hand flapping, rocking. Sometimes you'll find that they keep on pinching themselves, or they're moving their heads back and forward, or they are repeating one behavior over and over and over. No matter how many times you tell the child, stop hitting that oyster copy on the floor, it's hurting my head, the child will just keep on hitting it and hitting it and hitting it. That is what they're speaking about when they say repeated behaviors. And then we say inflexible adherence to routines and intense distress at changes. So at our special needs home called Little Gems, you are invited whenever you want to come to get in contact with Leanne or myself, to make arrangements for you to have a tour, and it will be very good for you to have a look around the home with special needs children, where you will pick up the autistic traits in these children. All right. They are not they do not deal well with changes. So if they are used to having a cup of tea after they have their hot dog every Thursday, and you do not give them that cup of tea because they lack the ability to communicate with you, they just start doing these behaviors. They start going on for themselves, and we just lose our minds also because we can't make out what the child wants. In the meantime, because the routine was broken, it really distresses that child or that adult for that matter, and they go into panic mode. All right. And then also another point to note is fixated interests with abnormal intensity of focus. So that means they will be obsessed with a certain thing, and they will watch, or they will play, or they will sing, or they will whatever that thing over and over and over and over, to such a point that it would drive a so-called normal person of the rocks. All right, so it's very intense, and it is very fixated, the interest that they have in this thing. It could be a pet, it could be a new toy, it could be a program on TV that they want you to play over and over and over, and no matter how many times they see the same joke, they keep on laughing at the same joke. All right. Lastly, we say sensory hyper reactivity and hypo reactivity. So what they're saying here is, it means that they either underreact to something or they overreact. So you can think to yourself, if a child is overreacting for something, a simple thing like you walk past the TV when they were watching their favorite show and they start throwing a tantrum, red flag. Now we look at an example of underreacting. The child gets a good hiding from whoever it is. We know it's outlawed, it's not supposed to happen, but anyway, the child gets a good hiding and the child does not react. Whereas a normal child of that age, of that stature, with that amount of um, hitting with the ruler would have cried. This child does not react in that way. All right, under or overreacting, that is what sensory hyper reactivity or hypo reactivity means. Leanne, I see something in the messages there. I can't read it. If you can just read it for us, please.
No problem. It just basically says that atypical means, or it refers to someone that is different. It's not. No, it's usually what we use to refer to someone that's got a disability, or in this case, autism. We refer to that as atypical, meaning that it is not. You can't say it's an abnormal child or there's something wrong with it. So it's just basically explaining the word atypical. So atypical is referred
Okay.
to as someone with a disability.
Okay. I think that's a nice word. That's a nice word. I heard a few words already. You can go to the next slide. People used to say differently abled. And I think the root of it all is that we just trying to be sensitive and not feel anybody or their loved ones, not make them feel offended by using words such as disabled or hey, ama kroko kroko, or all of these type of things. South Africa is a different country, but anyway, we carry on. The clinical profile and demographics. So here, we're looking at statistics now. We say prevalence and demographics, 1 to 2% of the world has it. Diagnosed 4 times more often in males, heavily underreported in females due to screening tool biases, and higher rates of masking. So with females, I'm saying here that people tend to hide um, and not take them for assessments and diagnosis. All right, so it's 4 times more in males that you will find reported, diagnosed, and doing some sort of therapy or schooling that caters to their needs compared to females. All right. And then on the cognitive profile, we say 40 to 80% feature an intellectual disability, but many display a highly uneven cognitive profile, extreme strengths paired with specific learning disabilities. All right. So when we see the word cognitive, also has to do with the way a person's mind works, their intellect, their intelligence, how clever they are. All right. So they say 40 to 80% of them are challenged intellectually. They can't think for themselves. But then remember, we said in Rain Man and in The Good Doctor, those guys were overly intelligent. So only the stats are telling us that it's only for 40 to 80%, not the entire world population that has been diagnosed with autism, is nonverbal, is unintelligent, is slow. Not at all. All right. Co-occurring conditions. 20 to 30% of these people are also diagnosed with epilepsy. High rates are associated with OCD, anxiety, depression, and insomnia. So, if you hear anybody speaking about that, have them go and check themselves out. You never know. Once they know what they have, what they can then educate themselves on how to deal with with the condition that they are living with, or with the condition that their loved one, their child, their niece, their neighbor, whoever it is, living with. All right. Next slide, Leanne. Can you tell me how many slides we have left?
Let me quickly check for you. Do you want me to do this one as well?
No, it's fine. While you check, I'll do this one. Is that okay?
Yes, it's fine.
Okay, thanks. All right. So early warning signs, 0 to 3 years old. Um, at 12 months, you will pick up that there is a lack of eye contact. The child doesn't look at you because they don't recognize a person as a person. They don't know what is a person. All right. No babbling, no pointing to things that they want, no responding when you're calling their names. So if at 12 months any of this is happening, please remember that you need to be aware, you need to be on the lookout for more signs, and if all those signs are pointing in the direction of autism, the child needs to be assessed. 16 to 24 months, no single words by 16 months, no two-worded phrases by 24 months. That tells us that there is a problem with the child. Now remember, it might not always be that the child must be assessed for autism. Sometimes children not looking at us, not responding, could be that they have a hearing problem. They might be deaf. So whenever we send for assessment, we need to not necessarily ask them to check 150 different things, but look at what other causes there might be instead of just brushing everything off as autism, because it's very easy to diagnose a hearing problem and you can do it for free at clinics and government hospitals. But to get diagnosis on special disorders such as autism takes quite a bit of time. All right, so first we rule out all the other physical and biological factors, like maybe there's no eye contact because the child is not responding because they can't hear properly. Maybe the child isn't looking at the people, or the child isn't standing up and walking or whatever because the child is blind. There could be other reasons. The crucial red flags, though, that we speak about is regression, any loss of previously acquired language or social skills before the age of 3. If the child was doing well and all of a sudden at the age of 3, this child starts going backwards now. He doesn't know the colors, he doesn't speak the way he used to speak. It's a red flag that we have to look out for. And then we speak about joint attention, which means mind blindness. Often manifests as touching or guiding a caregiver's hand to an object or interest rather than pointing at it. All right. So again, this reminds me so much of Little Gems. Um, if you guys get a chance, please come and pop by and look at our facility. You will see a lot of this happening all the time, that the child will not go himself to fetch something. You will grab the caregiver and you will point the caregiver's hand in that direction. We do not know why, we do not understand why, but we know that it's a very common trait in people with autism. All right. Any other questions? Please pop them in the question box. Leanne, have you got feedback for me?
Yes, there's only 6 slides left.
Okay, no problem.
Just
So we
to
should be done in
just
time.
No, yes, no problem. Just to add on to your statement that you made about touching the caregiver's hand and pointing them in that direction, that usually means they are communicating with the caregiver, because remember, they are non-verbal. So their way of communicating is by using gestures, by pointing, by even picking up the thing that they want them to look at. And they will kind of I don't know how to put it, like tap you, so to get your attention so you can look down at what they are specifically showing you at that stage. So just a way of them communicating with the caregiver.
Excellent stuff. Thanks, Leanne. All right, we are on our next slide now, and we speak about the lived experience, sensory and cognitive. Okay, so sensory, when we see the word sensory, we always remember senses, our 5 senses: smell, touch, taste, hearing, and eyesight. All right. So, okay, Leanne, there's a message in the question box. If you can check it for me, it's from Janani. Um, Number one, they say the environmental stimulus, the things that are in the environment that stimulates the child. The neurological amplifier for that would be heightened sensitivity in an autistic child, which means the brain amplifies raw input. It becomes extra loud, overlapping noises become an indecipherable wall of sound. Sensitivities to specific textures make eating or walking on wet grass overwhelming. All right. So, if we look at autistic people and we see them going ballistic and we see them going berserk, it's because, come I give you guys, okay, this is not a good example, maybe, but you don't want to compare humans with animals, but remember, there's a big thing in the world happening now because of fireworks. Lots of people are against it because animals, just the same way I assume, as people with autism, have an amplified version of everything. The way we hear it, they hear it much more louder than what it actually is. And if they're not hearing it, they feel it much more harder than everybody else feels it. So you could just, for example, touch them by the hand and they will start screaming because the skin is the sensory input of the skin is so sensitive that they are scared, that they scream out in pain. All right. And then they have a fascination with logic. The mind naturally seeks predictable patterns. However, autistic individuals may categorize objects individually rather than forming broader schemas, resulting in high objectivity and low framing basis. All right, so yeah, there we have it, a fascination with logic. They will go and scratch out stones and put all the green stones together, the blue stones together, and it doesn't make sense to any of us, but to them, it makes sense. All right, and then self regulation, stimming, moving hands, repeating sounds is not misbehavior, but a perfectly normal mechanism to adjust to an overwhelming sensory input. All right, so the purpose of all this high English on this slide is to basically just tell us that these people, the way we perceive things, the way we sense things, five senses, seeing, touch, smell, taste, um, and hearing, for them, everything is 10 times louder. Now remember, 10 times worse, the touch, 10 times louder, whatever the case may be. Remember, again, I'm going to repeat, we do not classify all autistic people on the same spectrum. It's a very broad spectrum. So, not all autistic people will have all the same symptoms. Some will have different reactions to sensory input. Some will have no reaction to sensory input. Remember, we said hyperactivity, overreaction, and hypoactivity, underreaction. It all depends on the individual and their reaction. All right, we do not generalize and we treat each case individually as per its merits. All right. Leanne, have you got the message from Janani?
Yes. So it says, "Hi, Sophia. We have a 3-year-old who does not respond when we call him. We, who is also on his own and does not interact with other children. Also not speaking, but makes some sounds. Can this be signs of autism?"
Okay, so again, I'm not a doctor. I would have loved to give my professional opinion on it, but I'm not a doctor. I would say the first recommendation would be to have the child go for audiology test, speech and therapy, where they test the child's hearing. It might be that the child is not able to hear properly, and that's why the child is not responding. At what age was that?
3.
Yeah. So, Janani, it's best to act fast and get the small things like I don't know if you were in the class earlier. We spoke about the small things like the audiology and the eyesight test and so on and so forth out of the way. Get that cleared, and then say, you know what? Ask the audiologist, the person that is doing the hearing test, the speech test. Ask them what they think the next referral point must be. If they pick up the problem, hurrah, maybe the child just has too much wax in his ears and they clean the wax out. You know,
Is
we hope it's as simple as that. But if it's not, then that professional will refer you to the next port of interest. If not, then please do ask out of your own. Yes, Leanne?
just remember the last class that we did was on the ears, especially when they had a lot of ear infections and a lot of problems with the ears itself. That can also be that it's just the ears. So I just wanted to add with the
Yeah.
ear infections.
Ear infection, 100%. And these small people, they have a liking to putting things in their ears. Even the special needs people have a liking to putting things in their ears. Janani, your hand is up. You may ask your question. Leanne, you can change the screen.
Okay, Sophia. with the child that's 3, is turning at the age of 4 now. So
Okay.
it does like move around. He's very fast learner. The
Okay.
only thing is when we speak to him, he does not respond. We can call
Okay.
him by his name,
Yeah.
and then he's always on his own, like looking at you see these grass, picking up sounds,
Okay.
doesn't interact with other children. But
Okay.
if you teach him something, he's a very fast learner.
Yeah. Okay. Okay. Um, I'm gonna say to you, Janani, are you keeping records of his behavior?
We do actually, we do
Okay.
keep records of his behavior.
Okay. And
But
have you made the parents aware?
unfortunately, he was with us for a while. Then the parents took him away to
Yeah.
another school. But unfortunately, some things happened at that school, so she brought him back again. So now
Okay.
wants us to help, but it's a little bit tricky because now he backlash to what we tried before.
Yes. Yes.
So now we have to start all over again to see if it's a speech delay or
Yeah.
is it something else.
Yeah. Yeah. No. I think uh your principal needs to step in at a certain point, if there's no progress or if there's a regression happening at a rapid rate. But as long as the parents are aware of the problem, you can't come at the end of the year after alles is nou klaar en nou wil jy nou vir die mense sê, actually we think your child has a problem. You understand?
Mm.
So, yeah. So as long as the parents are aware and the principal is aware, you just keep on keeping records on the behavior, on the non-responsiveness and stuff like that. And you submit that, like I said, once there's just too many red flags.
No problem. Thank you.
All right.
Bali's also got a question for her. Her hand was up, and then she also just left a message in the comment box. It says other parents are in denial, and we see these signs at work. How can I tell or advise the parent to go to a speech therapist or to see a professional doctor?
Okay. So thank you for the question, Bali. We said earlier on that if you are not the principal or the person in charge or the head of the department, you refer the case the to that person, the head of department, the principal, whoever is in charge above you. You do not directly approach parents. They find it very offensive, and maybe there's something that you didn't pick up, that your principal can pick up, that they can clarify and de-escalate the situation. Maybe it's just there was a bead stuck in the child's ear. I don't like that we're using hearing as an example all the time, but anyway, so yes, if it is a loved one, I know that story about being in denial. It happens all the time. They don't want to realize, they don't want to admit. All we can do is spread awareness. You know, have a conversation with your sister or your cousin or your nephew's father or whoever it is and say, listen, I've been watching uh, this child for the past few days. I've been doing assignments on learning disorders, and I've come across this, and I see these behaviors in the child, and I'm really concerned. You know, I think we need to look into it so that we can diagnose it and deal with it, so the child can have a better quality of life. Because I'm sure they must be suffering and feeling lonely in a world where they don't understand anybody and nobody's understanding them as well. Everybody's just seeing their behavior as being naughty or showing off or so on or so forth. All right. I hope that answers the question, Bali. All right, we're going to carry on. The lived experience, social disconnection, and masking. So there are visible behaviors and invisible behaviors. We spoke about this before: avoiding eye contact, missing subtle social cues, like waving. You wave at somebody, naturally the other person will wave. You're standing in a line, it's awkward. Everybody's looking at the ceiling because there's so many tills open, and ShopRite only have three cashiers, but there's 20 tills in ShopRite. And we look at each other and we just shake our heads with smile or something like that. Other people will also smile and shake their heads. A person with autism will look at you and wonder, why are you smiling at me? What do you want from me? Things like that. All right. So then normal social cues, they're not on par with it. They don't understand sarcasm. You can't be sarcastic with an autistic person. They will take what you're saying very, very literally. You know, break a leg, we know that means good luck, have a nice performance, enjoy the stage, do what you need to do, whatever, when somebody's performing in theater especially. But you tell an autistic person that, and they might actually just go break their legs. That's not a drastic example, but just so you have a basic idea. And they have emotional meltdowns. So they go ballistic. They act extremely, according to us, irrationally for whatever seems to be going wrong. It looks like it's blown out of proportion to us, but to them, because we said they hyper reactive, they will act in that certain way. So these are the visible behaviors. The invisible cognitive effort, we referring to what we spoke about earlier: mind blindness, difficulty reading complex. They're not able to read, maybe unpredictable human emotions, or imagining what others are thinking. They can't look at your face, see your expression, and understand what it is. Even if you look at them angry, they just carry on with their day like nothing matters, nothing happened. All right. And then there's masking, the exhausting conscious effort to hide neurodivergent traits to blend in, especially prevalent in females and adults. So, because of in some cases them having a very high intelligence, they can actually hide these visible behaviors because they have high intelligence. They will hide those behaviors, and people are not likely to pick it up. And they say this is very likely amongst females. All right. And then sensory overload, we spoke about that earlier, where they feel, hear, see, touch, and taste everything in extremes. All right. Emotional outbursts are often the direct result of a system overwhelmed by input, not defiance. So with sensory overload, because they're receiving so much information at such a high rate, at such a fast, loud, intense pace, they uh, are obviously suffering. They are not well, and they need assistance with that. And the reason why we say it's invisible is because you can't see that. You and I can't see that this person is hearing a thing 5 times louder than what it really is. Or this person is tasting this food 100 times stronger than what it really is. I didn't even put chilies in, I just put a little bit of peppercorns in there. But because of their hypersensitivity, they feel things in extreme. Their senses react in extremities. All right, Leanne, next slide. Do we have any questions in the message box? Doesn't look like it.
Next. No, next.
All right, now it's good. I hope I'm not boring anybody, guys. Remember, again, this is a reminder that if you don't understand anything, by tomorrow morning, Leanne or Nick will load it onto the portal and onto the WhatsApp and YouTube groups. You can always go back and listen to the lesson. I apologize for speaking so fast, but the reason is just simply that we don't want to cut too much into your personal time and make sure that we cover all the material in one session. All right, the assessment and diagnostic pathway. There are 3 steps to this: the assessing and the diagnosis. Assessing, step 1 is screening. Initial milestone tracking by a pediatrician. use of screening tools like childhood autism rating scales. That is totally not in our hands, that is in the hands of the professionals. So you brought it to the attention of the principal. The principal called the mom, had a nice cup of tea, sat down with her, showed her the reports that you have been collecting over the past 3 months, and informed her that they are concerned about her child. And then the mom then decides that, okay, please give me a report from the school so that I can go to the clinic because I'm not on medical aid. And then the clinic will say, all right, our screening person or our psychiatrist or our what pediatrician, whoever it is, only comes in at on Wednesdays. They give you an appointment, and then the mother goes for the appointment. Step 2 is specialist diagnosis. Clinical history and observation mapped to DSM-5 criteria, utilization of standardized tools, and ADOS observation schedule, and ADI interview. Like I said, too much high English. It's not our department to deal with anyway, so don't worry about it. That basically is just telling us after the screening, the pediatrician will refer them to whichever specialist they think the child must see. Like we said earlier on, sometimes it needs to be the audiologist, or sometimes the child isn't walking because there's something wrong with his foot, and they're going to send him now for to x-ray, to the sonar people. All right. And then step 3 is where they do the medical and genetic checks, full neurobiological exam, including head circumference to check for the macrocephaly, hearing tests, and genetic tests for dysmorphism. All right. Again, that is the field of the um, medical professionals. We are educational professionals, but this is just to give us an idea of what journey lies ahead, so we can explain that to the parent, because the parent will likely be very sad, demotivated. We can just tell them, listen, it's not the end of the world. What you can expect is screening. The child will be then sent to a specialist for diagnosis, and after that they will do a little more tests, and they will be able to tell you which type of autism your child has, because the spectrum is very, very broad. All right, next slide. Leanne, do you have any questions that you want to pose to the learners?
No.
Okay. Everybody's tired today, né? Tuesdays. All right. The multidisciplinary intervention matrix. So when we hear multi, we must always know that there are more than one discipline or more than one professional that gets involved with the diagnosis and the treatment and so on and so forth. All right. So the first professional, if it starts in your class and you picked it up, you're part of that multidisciplinary team, right? So behavioral and cognitive applied behavioral analysis to tech skills via small progressive changes, cognitive behavioral therapy for associated anxiety. So that would usually be the psychologist or the psychiatrist that would be involved in that. Then we speak about communication, and there, like we said, you will have the audiologist or the speech and hearing therapist give a report, do an assessment, and give a report on that. Then we speak about the pharmacological. They take into consideration all the medication that the child has been on or the parent was on while pregnant with the child, and how that may have influenced things or whatever the case may be. And then obviously again big on is physical and uh, sensorial professionals, such as occupational therapists, physiotherapists, people who do x-rays, people who do all of those type of things. And they basically step in once the diagnosis has been done. They basically step in and they work with that person to help that person become functional. Especially occupational therapists, they work very close with people that have physical challenges and help them to overcome those physical challenges by teaching their by teaching their muscles how to have memory with repetitive movements all the time. All right. So this is very interesting, the work that occupational therapists do. Something that fascinates me very much because not every patient is the same. You cannot be doing the same type of therapy on everybody. It's going to take a variety of different things that they're going to try out at first, different materials. And if you're lucky enough to be from the medical aid team, what would happen is they will actually come into your environment and they will see the setup that you have, and they will then recommend what you can implement in the environment to help this person live a better quality of life. All right. Enough about that. We go to our next slide. Okay. Actionable support in the home and in the classroom. So this is for us. All right. Structured communication. Number one, you use visual schedules and provide clear, literal, and direct instructions. Do not be sarcastic. Do not be sarcastic. They do not understand sarcasm. There must be a routine and you must be clear when you are speaking. I remember when we were small, when we used to say, huh? The old people used to say, huh? Dis verhasse met lang ore. Don't do such things to children, especially in your class. That's emotional abuse. Okay, guys? We know better, so we do better. The old people shame, I don't know what happened there. Anyway, another actionable support. We look at the environmental control. Proactively manage the environment to reduce sensory triggers. That is, you can dim the lights, you can put them into a quiet zone, you can turn the TV down, you don't have to play the radio so loud. That is just environmental control where you try, because remember, we said the sensors are hyper or hypo, right? And then social scaffolding. Encourage peer interactions and social stories to teach cooperation while strictly respecting the individual's comfort zone. So you're not going to force them. You're just going to tell them a story of this boy that used to play with his friends and how he had so much fun. And friends are not the enemy. Friends is not the boogeyman. I don't know, whatever you want to say. Just always be encouraging. Now remember, when they say scaffolding, it means picky for picky, a little bit at a time. Today we're going to have a play date with Tabo. And then you have a play date with Tabo for the next month, every Thursday and every Monday. Then after that, you say, okay, we're going to have a play date with Tabo and with his two cousins. So you introducing social interaction a little bit at a time. You cannot decide, wag, ons gaan nou social interaction doen. I'm taking you to a concert with 1,500 people. The child's going to go off their rockers. All right? We need to understand that it needs to be scaffolded, little by little, slowly, bikkie maak baie. All right, and then lastly, amongst the actions that we can do to support these children in our homes and in our classroom is consistently reward desired behaviors and celebrate achievements to build confidence. All right, so when they eventually get something, when they respond in the way that they're supposed to respond, or that you've been trying to get them to behave, you need to reward those behaviors. And it doesn't always mean that they need to go to McDonald's for a happy meal. No, it can be a simple thing as you giving them a fruit, or you allowing them to do something, or to watch an extra episode of something that they fixated on, so on and so forth. It is just up to us to be creative. It is up to us to watch attentively, watch carefully, and see what the child's interests are, and we use those interests to reward them. All right, next slide. Dismantling the myths. So one of the myths are that vaccines cause autism, but the facts are that extensive definitive evidence proves zero links between vaccines and autism. I know culturally and religiously there are a lot of people who do not take the vaccines, the normal early childhood development vaccines, because they believe that it is harmful. All right, we do not discriminate against them. This is just bringing awareness to us so that if we do come across those people, we don't go, "Oh my Lord, do you want the child to die? What is wrong with you?" No, no. They have a right to refuse medical treatment. They have a right to refuse immunizations, vaccines, all of those type of things. All right. Another myth: autistic children lack empathy and cannot learn. The facts are they are highly capable of learning, often excelling with uneven cognitive profiles, and empathy is deeply present, just expressed differently. All right, we spoke enough about that. We're going to go to our next myth: autism is just a childhood phase. The fact is that it's a lifelong neurodevelopmental variation that individuals grow and adapt with, but they do not outgrow. So there is no getting rid of autism. It's like if I was born colored, there is no getting rid of my coloredness, no matter how much I can put on Afrikaans accent here en vir julle vertel alles wat ek wil sê, you cannot get rid of it. That is how you are made, that is how you were born, that is how you are. So if a person is autistic, there's no medication that's going to cure it. In many cultures I know they also call it witchcraft, and oh Lord help us, witchcraft and curses, and because the mother did this and because the father did that. Those are all parts of myths that we need to dismantle. All right. In your spare time, read up as much as you can about autism. My advice for you will be, because the medical terms are so high language, go on to YouTube and go type in autism for dummies or autism for beginners, understanding autism for beginners, or I usually put for dummies, and they give you very simple basic things to understand and how you can then express it and explain it to the parents or to your principal or your HOD. All right. So to wrap it up, we say we need to embrace neurodiversity. Neuro, brain, and diversity is obviously a variation of brains, of variations of how people think, of how people process things, of how people use their brain, how they imagine, how they react, how they respond, how they interact with the world. Autism is not a broken version of a normal brain. It is an entirely different operational system. No two autistic individuals are alike. The objective of support is never to cure or force them to conform to society. No. But to maximize the quality of life, provide tailored accommodations. Like we said, the professionals will come into the house and show you what to do, what not to do. You must build a ramp here, you must not put that loud music on, etc., etc. And adjust society's stereotypical perspectives. That is our job as early childhood development practitioners, to ensure that these myths and all these stereotypes about people with autism, people with physical and mental challenges, they need to be dispelled. Enough. It's we in 2026. The world is full of AI by now. You would imagine that it would be gone, but lo and behold, people still hold on to those old folklore. I think that's what they call it. And then, lastly, we say for every grain of sand on earth, there are 10,000 stars in the universe. They are all kinds of autism. And that is the end of our presentation tonight. From me, it's a thank you very much for joining our class, and I hand you back to Leanne.
Thank you everyone for joining the class. Is there any last minute questions or anything that you would like to add or just want to know about?
I think they all want to go have supper, Leanne.
I think so. So let's just call it a night. Good night,
Yep.
everyone.
Good night, everyone.